Okay, in this video we will be discussing about polymyositis. What is polymyositis? It is basically an entity which comes under idiopathic inflammatory myositis. Idiopathic inflammatory myositis. What are the other entities which are studied under IIM? First is the polymyositis that we are going to discuss in this video. Second is dermatomyositis. We have already discussed it. And third is inclusion body myositis. These are closely related myositis. Others are immune mediated necrotizing myopathy and overlap syndrome or overlap myositis. Right. So these are the five entities that we study in idiopathic inflammatory myositis. In this video, our discussion will be limited to polymyositis only. Okay. Now, what are the clinical features of polymyositis? Uh, Polymyositis is again a heterogeneous group of disorders that usually presents with symmetric and proximal weakness. This is true with every kind of myositis except inclusion body myositis. See, IBM is an exception. It is an exception. So these findings will not be seen in IBM, but with polymyositis, dermatomyositis, immune-mediated necrotizing myopathy, we will see symmetric and proximal. The most important thing that we have to mug up is symmetric, means both sides, and proximal, means the shoulder girdle and hip girdle will be involved more than the small muscles, distal muscles. They are not involved in polymyositis or dermatomyositis, but IBM is an exception. Remember that. So polymyositis means symmetric and proximal. That worsens over several weeks to months. Means it is subacute kind of presentation. Right. As with dermatomyositis, there can be associated with heart, lung, and joint. As we discussed that in dermatomyositis, we have risk of cancer and other organ involvement. Most important was ILD, lung involvement, right? Similarly with polymyositis, but there is risk of cancer is lesser risk of cancer than with dermatomyositis. See, polymyositis, all the clinical features are similar to that of dermatomyositis, except that the risk of cancer is less in polymyositis because there are different set of antibodies involved. Pathogenesis is somewhat different, so lesser risk of CA than with dermatomyositis, right? Another important thing is that we have to look at the epidemiology. Females are involved more than males with the ratio of 3:1, right? Age of presentation is 40 to 50 years. Okay, 40 to 50 years old female coming to the OPD with proximal muscle weakness, right? There is no skin involvement. Okay, no skin involvement, only muscle involvement. If there is skin involvement, means it is dermatomyositis. Okay, now what are the lab features? Most important is CK levels, always elevated, because the muscle myositis is there. Muscle fibers are somewhat involved. We will be discussing the pathology or histopathology in the next slides, but for now we must understand that the muscles are involved somewhat, though not as much involved as they are in dermatomyositis, but muscles are also, involved to quite a large extent. Normal CK cannot be there. If there is normal CK, we have to rule out IBM. In IBM, there is normal CPK levels, not MB. MB is for heart. CPK levels, normal CPK levels. then it is IBM. In myositis, CK in this polymyositis, CK levels are always elevated. Antibodies. This is something which we need to mug up. First is the anti-synthetase antibody. Anti-Jo is most commonly involved. It is also associated with ILD. Right? If anti-Jo antibodies is found, the risk of ILD is very high. Anti-SRP antibody. It is a marker of disease activity. Anti-helicase antibody. Two are the most important: anti-TIF1 and anti-NXP2. Anti-TIF1 is associated with malignancy most often. I mean, strongest correlation with CA is with anti-TIF1 antibody, though anti-NXP2 is also associated with malignancy, but more important is anti-TIF1. Anti-MDA5 antibody is associated with ILD, right? If anti-MDA5 is present, ILD का risk ज़्यादा है. Anti-synthetase में anti-Jo is also associated with high risk of ILD, right? Histopathology. I mean, what we will see when we uh, when we cut a section of the muscle fibers. Uh, See, what is there written in the textbooks is very hodgepodge kind of thing, very confusing kind of things. For example, they say कि muscle pathology varies substantially, but for the sake of understanding, we have to remember that the muscle fibers are definitely invaded in polymyositis. No if, no but. Muscles are definitely invaded by inflammatory infiltrates. CD8 cells are involved, right? CD8 cells are responsible for the invasion of muscle fibers. They invade the muscle fibers. They cause damage to the individual muscle fibers. Muscle fibers get atrophied, and that is what is visible in histopathological examination. Invasion of muscle fibers, CD8 cells, endomysial location, right? This is most important, though there is perimysial and perivascular region also, but we have to remember endomysial because in dermatomyositis there is no endomysial involvement, only perimysial and only perimysial and perivascular invasion, no endomysial. But if there is endomysial, there has to be polymyositis. This is one thing which differentiates between polymyositis and dermatomyositis, though dermatomyositis is also associated with skin changes, right? So this is what is seen. Now in this slide we will see that how the muscle fibers are invaded. See, there is endomysial involvement, CD8 cells. These are the muscle fibers. This muscle fiber is not invaded by the cells because cells are lying outside the muscle fiber, right? But see this muscle fiber, it is invaded by the inflammatory infiltrates, right? And it is atrophied. It is involved. It is atrophic. Let me clear it once. Now you will be able to appreciate that this muscle fiber is involved and this is atrophic, right? This is atrophic muscle fiber. Though there is involvement here and there is a large amount of involvement of muscle fibers by the inflammatory infiltrates. The cells are invaded. They are not just outside the cell, they are invaded. They invade the cells. They enter the cells, they cause atrophy. That is what is the distinguishing feature of polymyositis when compared to dermatomyositis. Now we can see the slide of thing. Rather in polymyositis, the muscle fibers are invaded, right? So this is the differentiating features. This is very important. We have to remember it. Treatment. Polymyositis is responsive to immunotherapy, as with uh, dermatomyositis. This is also responsive to immunotherapy. We give high dose glucocorticoids, prednisone, which is oral drug, 1 mg per kg per day. It is the first line treatment. सेकेंड लाइन ट्रीटमेंट हम कब शुरू करते हैं? सेकेंड लाइन है क्या? मिथोट्रेक्सेट. दो अदर भी हैं, बट वी स्टार्ट विद मिथोट्रेक्सेट. कब करेंगे? अगर कोई दूसरा ऑर्गन इन्वॉल्व है, फॉर एग्जांपल मायोकार्डाइटिस है या आईएलडी. स्टीरॉयड कॉम्प्लिकेशन का ज़्यादा रिस्क है. पोस्ट मेनोपॉजल वुमेन में ज़्यादा रिस्क होता है, ऑस्टियोपोरोसिस में रिस्क होता है, डायबिटिक्स में रिस्क होता है. तो उस सिचुएशन में वी विल स्टार्ट मिथोट्रेक्सेट, राइट? We will add methotrexate and we will reduce the dose of steroid. Then with time we will start tapering the steroid and we will take up the patient on methotrexate only. Who fails significantly to improve, जिनके ऊपर काम ही नहीं कर रहा स्टीरॉयड, तो हमें ऐड करना पड़ेगा सेकेंड लाइन एजेंट. अगर हम टेपर नहीं कर पा रहे प्रेडनिसोन, तो हमें ऐड करना पड़ेगा methotrexate. So these are the indications of second line drug therapy addition. Right, so this is the treatment: prednisone and second line addition of the methotrexate. Prognosis: patients improve with immunotherapy, but we have to give lifelong treatment. Poor prognostic features are cancer, though the risk is more with dermatomyositis, but risk is there with polymyositis also, though to a very less extent. More the age, more poor the prognosis. लंग और कार्डियक इन्वॉल्वमेंट, लेट और प्रीवियसली इनएडिक्वेट ट्रीटमेंट. पहले कभी ट्रीटमेंट नहीं हुआ अच्छे से, अब नुकसान ज़्यादा हो गया, तो आई मीन दिस इज अ पुअर प्रोग्नोस्टिक साइन. लंग और कार्डियक इन्वॉल्वमेंट, if it is there, the risk is, the prognosis is poor. Age and cancer are there also. Another bonus slide that we have with us is overlap syndrome. What is overlap syndrome? When dermatomyositis or polymyositis is associated with other well-defined connective tissue diseases like scleroderma, mixed connective tissue disease, Sjogren, SLE-RA. अगर Sjogren, SLE-RA, scleroderma, MCTD के साथ हमें polymyositis या dermatomyositis देखने को मिल रहा है, तो we use the term overlap syndrome. Okay, this is for the purpose of knowledge only. Questions are asked to a very less extent on this overlap syndrome, rarely asked. But yes, myositis are important. All the kind of myositis, whether it be dermatomyositis, very important, because they ask the questions on the skin changes, the Gauthran's papules, Gauthran's plaques, or Gauthran's sign, right, neck sign, V sign, shawl sign. Then the very important is these muscle fiber, the images of the histopathologies. They will give you the image and they will ask the diagnosis. So you have to be very thorough with the lab findings and histopathologic findings along with clinical features of different myositis. So this is the entity. What? It is polymyositis, which comes under idiopathic inflammatory myositis. That is all for this video. Thank you so very much for your patient listening.